problem.
There we go. Thank you.
Well, I'm excited to talk to a Kansas City group, and I realized as I was preparing for this that it had been a while since we talked about CHAMP cardiac, and so as I was putting something together, I realized that the best person to go over this was one of our patients and families that had experienced this. So I'm going to pull up a quick video, and I do have a few slides, but really just to have us able to have some placeholders to talk through what we've done over the years, and then happy to take any questions. Let me pull this up real quick.
And Lori, I think it's playing without sound. Is that true for everybody?
Yes.
Oh,
yes. Man. You might have to join or share your video with sound option.
Let's see.
And I think it asks you that when you're sharing.
Share. That's why you have IT on with you.
We use Teams, so I'm not exactly sure how Zoom does that, but when you're sharing your screen, there should be a checkbox or something, I believe, that allows you to do it with sound.
I see that now. Okay.
I think in the back of each of our minds, we were planning a little funeral, and just didn't know where it would go after he was born.
We'd hear a song on the radio, and we'd be like, maybe that's one we'd like at his funeral.
Winston was diagnosed with HLHS, which is hypoplastic left heart syndrome.
1 in 100 to about 125 babies are born with heart disease every year. And out of those, about 1% are born with half a heart. Out of all the heart surgery we do, this is the most high risk. They lose about 25% of these babies in between the two surgeries.
The standard of care at the time was to send these families home with a weighing scale and a pulse oximeter and a 3-ring binder, and they were asked to record measurements of their baby every day.
So we needed a method that we could actually send something home with the parents so that we could better monitor and be alerted if there were conditions that we were concerned about with the patient. We have a Microsoft Surface that we load our software on. We call it CHAMP. We decided we wanted to use a modern app with Windows 10 as the operating system.
We would log all of his vitals, and that app became this seamless piece to his care.
With the daily reports that come in from the Azure cloud, if anything is an outlier that needs to be notified to us immediately, it'll alert us.
One night, we're debating, do we call, do we not call? But we logged it in.
When we were looking at his information, he had a couple days of not gaining weight. He was breathing a little bit harder, and he just wasn't happy on his video.
You could pull it from when he was doing fine and saying, okay, a couple weeks ago, this is what he looked like. Now he looks like this. We think it is part of his aorta.
We were scared. It was real fast.
They did the procedure the next day, and then I think he went home the day after.
This technology literally saved his life.
The first time that I heard a child's life had been saved with CHAMP, I left the room because I kind of needed to tear up in private because it was a dream that I'd had for a long time.
The goal is to get this out to as many patients as possible so that we can help save kids' lives throughout the world eventually.
For everyone behind the scenes, we're very thankful for it. Saved his life, and how do you say thank you for that?
Well, I know that's a lot for 8:30 in the morning, but I felt like really what a great testament, and PowerPoint doesn't do it justice, of all that they've been through. And Emily is Winston's mom, and she says it best that thank you for all the people behind the scenes. And that's really what I wanted to share with you, of like how we did that. And hopefully you didn't snicker at Microsoft Windows 10 being a new app. Like I know this was in 2000, 12. Like, we started this a long time ago. So when I look at some of the things we've done, it's interesting to see where we've been over the years. And let me share just for some placeholders for me. All right, there we go. So when we go through what they've been through the enter stage, our idea was in 2012, so that's been almost 10 years ago, how can we help the babies in between that first 2 surgeries? And it's about 6 months of time, but the standard then was often babies were dying at home, and that's just not okay. And so from the healthcare innovation standpoint, you have to innovate to save lives, and if you don't innovate, you're going to stand still and things aren't going to ever get any better. And you're not going to get kids to age 3 when that video was taken for him. But when you take into account from people like me and Amy and Melissa and Kylie are the nurses, is we teach the families all the things they need to do at home. And then add on that they have meds, they have oxygen saturations that are abnormal, we have them weigh, they have feeding issues, and then the parents are worried. At that time in 2014, everybody pretty much had phones, but we started it on a Surface tablet. It's now available for mobile download from the App Store. But then you have all of this. Parents are worried about finances, there's transportation issues, they continue to have to work, they may live far away, and some of this is an uphill battle. But we took it in pieces, and our model really was to provide remote patient monitoring as a continuum of care. It doesn't replace any visits, but it helps when the family understands what they're going to communicate with their clinical team about and why. It helps the team to be proactive with that data as they get data from the app, and then prepared of what to do with it when there are things that are wrong, like in Winston's video. It also really helps in the literature. I didn't make this an academic talk because that's not our goal, but it really helps with productive encounters as a supplement to when they are seen in person or via telemedicine, they know what's been happening at home, and there's no parking lot effect that they're writing down in the binder or in the waiting room. I swear Amy always knew when they used the same pen color that they had just been writing it down in the waiting room. She could smell that out. And that has shown to improve outcomes, and not just with our patient population, but with others, that helping that continuum really provides a new distinct care area. In the last 2 years, COVID and having families at home have really pushed remote patient monitoring in the forefront. But I think the model that we developed from the beginning really still stands for any kind of condition. So I wanted to share this with you as what our 5-pronged approach is the patient and family at the center, and then 5 areas of the clinical team, the CHAMP platform, the IT team, the administrative team, and then the research team. So our clinical team really is the bread and butter, and I'm glad that a lot of them logged on today to see this, because it takes a village, and they take all of the information that we talked about to keep, this is a second surgery patient, to keep kids smiling there. And they start during the inpatient service, and sometimes even fetal, with meeting the families. And they go over all the things that the families are going to need to know. And I'm glad that Melissa logged on, because she's really an advocate for parental stress and parental coping during this. Because I don't know if any of you are parents, but I remember feeling illy unprepared when I took my infant home. And then add on that your child has half a heart and they have 5 meds, and the team's going to check oxygen saturations and what to call about. So it really takes all of these people. Melissa did a fantastic job with making a roadmap a couple years ago. And these are all the things, and it may be a little fuzzy for you, that we go through even just to get to home. So all the things that the baby goes through in the ICU is orange. All the blue things are the things that we do education about on the step down unit. But this roadmap and working collaboratively with the family is so important. And you'll see in there, CHAMP app is only one of that. It's only that one piece that helps the data transfer. So the families really have that proactive ability to say, I know what I'm going to call about. So the app itself, like we referred to, it's available in the App Store now. You can go download it. You won't get very far because you're not a patient or family, but you can look at what we have. It's in the App Store and Google Play. And we have a clinical dashboard that the clinicians use. There's paging and daily reports. There's weekly reports that are summaries that go to outside providers. And honestly, the majority of our families use it by their own phones, so they bring their own phones, but we still do provide it by an iPad if the family has not ability to bring their own phone. It's available in 9 languages, but English and Spanish is the most commonly used. Here's what the parent interface looks like, and just shout out to a majority of our development over this years were from the Claire Giannini Fund. And so we've been philanthropy funded up until the last 2 years, which has been amazing. Just some simple user interface, because we do, you know, we've had a 2nd grade education Spanish speaking mother. Like, we have a very simple, easy to use interface that goes back and forth, and parents will log their info. It does some conversions for them and some general red flags of what they should call about. This is reminders of what they should be concerned about. And, you know, it's very helpful for our non-English speaking families because they can use this to page us. So this will be in their native language, and it can say, you know, cyanotic or whatever in their looking bluer. And then the team then doesn't have to worry about them calling through the on-call provider, waiting for the pager to come to the fellow. There's a team dedicated 24/7 that answers these concerns. So since you guys are the health innovation team, you probably are like, yeah, that looks great up front, but what's under the hood? And so just for Children's Mercy patients, we started with our data from multiple families. It comes through, it's transferred to the cloud database, and then we get the outputs. But under the hood is a little closer. We have the tablet or the mobile version at home. It comes up through cell service, or they can hook it to Wi-Fi. We started it in a proprietary software called Heart Center, but now it's in an Azure cloud since, I don't know, 2016. But within that, we have an encrypted web service, daily reports to the clinical team, weekly reports to the parents, real-time analytics. And we also have a HL7 secure FTP server that goes into EMRs. So we started with this model and realized that pretty quickly other hospitals are going to want it. And that's part of why we shifted to put things into the cloud. But this took time, a lot of things under the hood, and a lot of people to do. So it's been an iterative process, lots of pivots, but it's an amazing thing that it's been a little bit since I went back and looked at it. And once you step away and watch things like that video, it's awesome to see what we've done. This is what the provider portal looks like. We have now, and this is what a patient would look like for the provider. And all of these little dots are a data point that the family has entered, oxygen saturations, heart rates, the blue dots are weight gain, and then the purple are videos. This is a parent report. We make it very pretty and colored for the parents, and lots of feedback from them of this. And this is kind of what it looks like in the EMR. And then without this kind of vision to say, other people are going to want this, the administration portion is important. And so we use the Azure Cloud build, and we're able to replicate this and use this at other centers. We didn't intend for it to be a rural healthcare application technically, but it ended up being that way. And it really, remote patient monitoring is remote. Like, we have some families that are 8 hours from us that take a crop dusting plane to get to clinic with us. No joke, that happened. But we signed groups like Seattle and Utah. And so over the last 7 years, since we've had other hospitals that we've expanded and use our app with their care teams, we've taught them how to use it. They have legal and research agreements with us, because I didn't say too much about it, but all of this clinical data they use clinically, but then we can do research on the back end. But more than half the families live 100 miles away from their care center. The only one that's usually really close is in Washington, DC. But it was climbing a mountain, and it's been great over the years to see that families can go home. They don't have to live at Ronald McDonald next to their centers. They can use this data and Over 800 families have used it. In the multi-site model, we have, I think, 500,000 data points and 48,000 videos. And we maintain a 3% mortality. That's 3% too much, but it's down from 25%. So we continue to strive to do better and help any of those and learn from each one of those times. And then the last thing is the research team. And like John said, I'm Dr. Lori Erickson, and this work motivated me to go back and get my PhD in research. And so I'm solely a research nerd now, and I work with remote health solutions. And so I don't have the clinical impact as much, but it's so important to get these publications out so others can learn from what we've done. So some innovation publications, some quantitative comparison analysis. Melissa did a fantastic qualitative report. I've done a concept analysis about the interstage and adherence. And then Dr. Ali just came out with a video scoring system trying to put a number to what we see in those videos. But really, none of that is important except for things like this. This is Winston now in the video. He is in 2nd grade. He is taking golf lessons, and he told his pro he has to be very good at golf because he is has hypoplastic left heart syndrome and it's hard for him to run. So that's why we do this. We keep the families at center of this and keep it in the right space. And I like I said, I'm glad to talk to Kansas City group because I'm from Midwest Kansas, and I don't share this in all my talks, but Winston's parents, I went to high school with his dad. What an impact that you can have from like the Kansas City area to work and help with patients and families that you actually know. So I think that's awesome. And I wanted to just kind of put my contact information for our CHAMP app and then my information. And then if you hadn't worked with our Center for Pediatric Innovation, or if you have an idea, working with pediatric hospitals, it's only about 5 to 8% of innovation out there, because some may say red tape, and we just say safety bumpers, because these are kids. They do require a little extra work, but if you have ideas, we would love to hear from you. And then just a plug, since some of you guys are earlier groups, some are more founded, but there's a group called Kids X Accelerator that is has open call for ideas, and they have a wish list about software and software innovation, and they put you in touch with pediatric hospitals. And Krista is the secretary for this International Society of Pediatric Innovation, and I've had good work with the iSpy group, so I just wanted to plug that if you guys are interested. So I'm going to stop sharing. Hopefully I didn't bring the mood down too much, but I appreciate the time to go through what we've done.
No, that's very good, Lori. Thank you so much. It seems that just the change in an individual's life first and foremost, but then the statistics of the dramatic drop in mortality is really something that so many people who are in the innovation space do not get the chance to measure. So I think it's really very vital. And as I understand it, you also won a Microsoft award associated with this innovation.
Yeah, you know, I started to put our awards on there, and we're funny. And it's like, we don't really like the awards. Like, yes, we got the HIMSS award, and the nurses won an International Nursing Award. And the Peter and Amy, they kind of hate, and Jenny, they're like, you got to go do the talks, because it is like, they like to stay just keeping the families and their outcomes forefront. And
right.
So I took those off of our slides, because that's not what we're in it for, but it helps us to continue to do more in this space when we do get that recognition. So it is an important part of it.
Yes, very much so. Are there questions from the group? We've just seen very exciting stuff here.
Yeah, this is Doug O'Hulan. Great presentation, Lori. I work on connecting the unconnected. And so given rural focus, what's the challenge of rural connectivity for your program?
You know, on the map there, our probably biggest challenge was when we signed West Virginia. Families would have to walk up out of the holler that they lived in to get connectivity in their in their area. And it's making the devices that we send home shifting to iPads, because a lot of families do have Wi-Fi now, has been, and so it's been an iterative process over the years. Melissa likes to tell the story of when we reached out to, I don't know if it was Verizon or AT&T, and asked them to turn a tower to try to get connectivity in remote Kansas. And she was like, wow, you got power. I'm like, no, I just ask. Like, we just ask and do the right things for families. And so since we've moved off of cell service and given Wi-Fi and parent download an option, our connectivity has improved. And we haven't had as much issues with video transfer. In the first 2 years, we had some of that, but I don't know, Peter and Amy, do you feel like we have issues now with connectivity at home or the clinical team?
Not so much. And just to kind of elaborate on that too, is when we first started, we did choose both Verizon and AT&T to be kind of carriers. So we got to pick and choose what worked best for some of the regions and the families. But to Lori's point, switching over to a mobile device where it can be used on the Wi-Fi was kind of a big step forward as well. So not too many connectivity issues recently. Back in 2012, of course, there were a lot more than there are today, just because of technology enhancements and, you know, where towers are being built and those sort of things, but we're doing much better today.
Okay, excellent. Yeah, just one last comment is the new Jobs Act that just came out, Infrastructure Jobs Act, has $65 billion to improve broadband for, you know, education. So that may be something to look at, you know, for potential funding on how some of your you know, the families could get connectivity who don't have connectivity.
Yeah, we've been kind of watching the news too, and what the government's doing on, you know, rural area internet speeds and connections and stuff. So that's always kind of something I'm watching on the background.
Okay.
And I did hear somebody say that they worked with Medicaid, maybe insurance stuff. So as a plug, we do, since it's providers reviewing all this data, we do code for remote patient monitoring billing codes. And Medicaid is not one that reimburses. So we are working closely with our government relations to show them the outcomes, show them the reduction in mortality and ICU stays. And so if you have an interest in that and want to meet, I don't know how I made remote patient monitoring billing my hill to die on, but I am trying to get this for our families and working towards having pediatric reimbursement, so more hospitals may be able to use it as one of our goals over these next 2 years.
No, that's a very significant point, Lori. The remote patient monitoring reimbursing came primarily through Medicare, so it would only be Medicare patients originally for eligibility. So to extend that to children is a very big step.
Mm-hmm. Private insurances are reimbursing for the majority of them, but Medicaid so far is not.
I see.
In Kansas and Missouri, at least.
Okay. Other questions from the team?
Hey, Dr. Erickson. Thanks for the presentation. I was interested in something that you mentioned. About 2 years ago, you said you guys not lost, but stopped getting grant funding or philanthropic funding. How have you guys moved to a different model, or what's the sustainability model right now for the program or other hospitals using this type of app?
So since we are clinical use, but a research registry on the back end, we maintain just a low membership fee, mainly to maintain that clinical registry. So each site helps, or each site that agrees to continue has a yearly membership, and they pay that fee. And it was hard for us as the ones who were out there in the front line to switch to that having to pay, but we didn't want to lose this option as the funding ran out. And I do a lot of grant submissions, and we want to be able to have more centers use it. But I mean, I think it was pretty self-sufficient that we maintained one grant for 7 years. So this fall is the first time that we've required payments.
So do you guys have a plan to make it more commercially available? And I say like commercial because like there's a difference between like a membership fee versus saying, hey, there's value in this and you guys should pay it.
Yeah. you know, definitely. I think part of our angst over the years was we were all the clinical team and we did this as part of our work. And so now that we have a new hospital support with remote health solutions as a division, we really want to make CHAMP cardiac inclusive and not exclusive. We had a very tight population that we could use the app for. And I did not like that we had to say, well, your baby doesn't have this exact thing, so they can't use it. And so we've now expanded criteria. Any heart patient that the heart center teams across all the hospitals that use it can enroll. And so that's our first step. And then we are thinking about potentially, are there centers that would want to just use this and not have that research portion on the back end? I was surprised as we shifted from non-pay to pay. No one was really pushing for that. So it was interesting, but we are looking at expanding to different non-cardiac groups. And I think those non-cardiac groups may want more of that, not having to enter as much data in. I think the heart nerds, we're just nerds and we're all used to registries. So it is definitely something that's part of our new focus, and it may help with sustainability and also going international, because there's more research red tape in when you have US research versus international, and having a commercial version might be where we go.
Thank you.
It seems that though you kind of reflect the questionnaire part of this as being maybe a little bit burdensome, the other side of it though is that having that capacity allows you to do things like psychosocial information, social determinants, those kinds of things, of being able to capture more data from the household that really rounds out the picture of the person you're dealing with.
Yeah, it is. We can't learn if we don't know what's happening there. So you know, and how many patients do you have to say you've reached saturation when it's such a rare group? So even over 7 years and 12 hospitals, it's only 800 kids. Well, in an adult space, you'd have 800 adults with, you know, CHF in 2 months. And so I think that's something that we want to continue the research registry, but we take it cautiously because we know the people entering data are the people like Melissa. Like, I know her and Kylie are going to rounds right now. So, you know, it's a fine balance of that.
I had a follow-up that I just remembered. Why was there that inclusion criteria for previous patients? Was it for research purposes or something else?
So hypoplastic left heart syndrome and single ventricle heart disease had a very set criteria of like red flags and what they called about and what we could look for in the algorithms. And then when we started so we wanted to start with something that we could easily take the problem and apply the paging and then learn from it. And so we wrote our research registry and inclusion and legal documents all as single ventricle congenital heart disease. And that was our goal. And I think that it took us a little bit longer than we had hoped to be able to say all complex congenital heart disease. Like, we have a lot of like matrix algorithms, like the paging's different based on your heart disease. And I think that it was just like, we grew a good thing. And it just took us a little bit longer to expand that criteria, but it was specifically for that population too, because they were the highest risk mortality. So we picked the highest risk and then had a trickle down effect.
Awesome. Thank you. I think I'm going to keep nerding out, so I might just grab your email and ask questions later.
Sounds good. I did want to plug that if anybody wants to come work with us, we have a software engineer portion position posted on Children's Mercy's website. So if you want to work with Pete, we're pretty cool. We're nerds, but if you got any friends that want to come work with us, please send them our way.
It's the kind of plug that we're happy to do.
Yeah, and just a plug for that too. From an IT perspective, this was a really life-changing project for me. I come from corporate, America IT, where you are a cog in a corporate machine. Working for the Heart Center, working with Lori, and working with this program and project was definitely life-changing for me and my entire team from like a career and IT perspective. So we love what we do, and this has been a fantastic thing.
That's great. Thank you, Peter. Well, other thoughts from the team, comments or questions?
Thank you guys for having us. I'm sorry I didn't warn that the video sometimes gets people. I came real hard at 8:30 with the tearjerker.
Still gets me every single time.
You know, I haven't watched it, Peter, in a long time. And that's why I reached out to the mom. I just was like, thank you for sharing what a, you know, crazy fragile story that you guys went through so early. And she was like, of course, here's an updated picture of our second grader. So it's very cool.
That's absolutely great. Yeah, it's innovation, but you can bring it into its reality, and that's what's so much more fulfilling and makes it all worthwhile. I was commenting on Amazon Web Services has just set up a digital innovation program with UC San Diego, I believe. And I was commenting on that, that I hope that they understand that it really isn't so much about the technology as it is about how you engage with people and what your strategy is for both engagement and sustainability. And it seems like that is very much a part of what the work that you're doing, is that it really is being there with the people where they are, both geographically and within their journey.
Definitely. And Amy Roberts said, I just was reviewing the chat. Yes, Children's just got their official adult accreditation for an adult congenital heart disease official group. We've always been doing that, but there's a nurse coordinator and a whole care team that's focused because more and more patients are surviving and thriving as adults, and they weren't having a place that they could go easily for care. So appreciate the shout out. I don't really know what to do with my patients if they can walk or talk. I'm really focused down in the small age, so that's not me so much.
That's great.
Thank you, guys.
Okay, yeah, thank you, Lori, and thank you for your posse being able to attend with us. As I said, you guys are welcome at any time. These are open meetings, and we love to be able to chat about what's really going on in the space, particularly in the local community. So your presentation was very welcome, and I can tell from everybody very well received. So thank you so much.
Very good. I'm excited to hear about MD Matchup too.
Okay, very good. Well, with that, we'll move on to introduce Bob Waddell, who's the vice president and co-founder of MD Matchup, looking at how patient preferences matter. So Bob, if you'd like to take off with that, you're welcome to do so.
Yeah, thank you. I'm going to share my screen here too. And John, I appreciate the invitation. And before I get started, just wanted to tell Dr. Erickson and her team, congratulations on everything you guys have been doing. That's fantastic. And it's awesome to see. So yeah, so just to give you some context, I guess, of where we're building. We're a startup, been around for a couple of years. And we were kind of born inside of an ad agency, and my background's healthcare marketing. And so I've worked with health systems to help them kind of drive patient volumes and help retain patients, for the last decade or so. But, as we work with specifically the marketing folks within those health systems, right? I mean, they're targeting all of these patients out there who are undoctored, right? I mean, there's 57 million adults out there who don't have a PCP. And even beyond that, across the generations, going from Gen Z or millennials all the way up to baby boomers, I mean, anywhere between 20 to 50% of those folks are looking to switch doctors in the next few years. They're at least open to that idea. So we call these people patient-free agents, right? I mean, they're out there and they're open to the possibility of switching providers. And I think for a lot of health systems, right, it's a little bit, they know that they need to create some sort of patient stickiness, but it's a little unnerving to know that loyalty isn't as prevalent as maybe as it was 20, 30 years ago. So the issue is when most people are going to look for a new provider, whether that's they're just moving into town or they don't like the provider's retired, the criteria that they're focusing on for half of Americans is really based around compatibility. It's around relationships, it's around personality. But the problem is that there's really no way for them to search for that criteria within the current system. And to go along with that, billions of dollars are spent every year by health systems specifically to attract these patients into their networks, right? And not only that, but help retain them as well. So the issue is if all that money is being spent out there to drive them into the networks, but if they're getting driven to providers who may be incongruent for them or non-compatible or non-complementary at the very least, that's going to affect their patient outcomes. It's going to affect margins for the network, and it's also going to affect reputations for the providers and possibly the network itself, right? I think we can all agree that there's probably nothing worse than a bad first appointment with a provider, because you feel like you've wasted your time. The providers feel like they've wasted their time. They're not sure if they're ever going to see you again. And so when patients are out there, they're looking for that trust and fit with a provider. They want to, the basis of any good relationship is trust. And so that's definitely very important for the patient and provider to have that level of trust. The providers are actually looking to have more of a say in who they attract to their clinics as well, right? I mean, we kind of joke internally that MD stands for marketing director, because a lot of times that we're working with the marketing departments and they say they've got physicians coming and knocking on their doors asking why their face isn't up on a billboard, right? And so I get it, but at the same time, you can't do that for everybody. So there's just no way for them to really be out there and tell people who they are in a concise way, or have people find them in that way. So health systems, again, they're looking for those sticky relationships. They really want to push patients to the proper points of care, right? I mean, obviously that's how they're going to get reimbursed in better ways, and they want to keep people out of the ED. And if they're going to their primary care provider and staying up on their health and if they have to go see a specialist, if it's recommended, that's great. But it's really about keeping those patients satisfied. And obviously in the times of COVID and beyond, keeping those providers satisfied as well. A lot of burnout happening right now. And so that's definitely top of mind for a lot of health systems. And then on the payer side, they're looking for more compliant members who are really staying within network, to get those cost savings and really focusing on that value-based care. So right now, there's a lot of ways for people when they're searching for a provider to find one, whether it's word of mouth. If you just moved to town, you don't know anybody, you may ask a neighbor or a coworker, hey, where do you go? It might be a location that's close to your house or close to work. Might be one of the billions of dollars worth of advertising that you see out there on a daily basis. But the one thing I do know is that Find a Doc tools were not built necessarily for patient loyalty. They were not built for the patient at all. They were built to fill provider panels, right? It's strictly a utility tool to get people into the funnel. And for the most part, health systems have not cared as much about who the patient goes to see necessarily, specifically on the PCP side, as long as they're going to see somebody, right? They just want to get them in the system. But that experience isn't necessarily a good one for the patient. And so the whole Find a Doc experience has been one-sided. So 80% of people inevitably go online to find a provider or do research, right? Most of those folks end up using some sort of Find a Doc tool, whether it's on a health system's website or a payer network site or even a consumer site. The problem is that all of the information that they can find out there is about the provider. And I understand it is called Find a Doc, right? But it really should be about finding a health partner. And again, trying to build those better relationships and taking into account information from the patients, because right now no questions are asked of the patients. And so there's just limited predictors of success for them out there to judge on and see who might be a good fit for them. And so really that shift to value-based care really requires that the whole experience be patient-driven. It really needs to be focused on the patient. Yes, we need more data from the providers as well, but considering the fact that we have no patient data right now, except for maybe we ask them, what insurance do you have? Or, what's your zip code or something like that, right? But beyond that, there's little information that we really know about these patients before their first appointments. And so we really see the opportunity to take that Find a Doc experience and really, make it a better tool, a better experience for the patient, to make it a marketing opportunity for the health system. And the way we can do that is by taking that data from the patient, taking more data from the providers, understanding who they are as people, who they are as professionals, or just as patients, right? And so understanding what their needs are, what their preferences look like, what kind of personality do they have? You want to have a good relationship. It starts from a personality standpoint. What are your priorities as a patient? What are your priorities as a provider? What kind of learning style methods do you like? Do you learn best from? How do you communicate well? So we're trying to gather all of this information firsthand from patients and providers, and I'll talk through how we do that here in a second. But once we get that information, we can put together through an algorithm who good matches will be in the system for these patients. And so beyond that, they can go ahead and use those traditional filters that they normally would, right? Whether that's quality or language or, anything like that from an insurance standpoint. They can use those filters to narrow their search down and find the best matches for them in the network. So we've created this product called MD Matchup. We call it the matchmaking app for value-based care. Again, really about as we moved away from fee-for-service into value-based care, the heart of that is really about that relationship. And so we're trying to build better relationships. So we use predictive matching through a proprietary quiz and algorithm. So we give a 10-point quiz to the consumer/patient, and we give about a 30-point questionnaire to the provider. And this predictive matching allows us to eliminate the guessing games that patients have to play when they're going through and using a traditional Find a Doc tool. If you know exactly what you want in a provider, using a normal Find a Doc tool is fine. And that's the case for some folks. The issue is most people don't know what they want in a provider, but they can answer some questions about themselves. And so that's what we're trying to do, is we're trying to get them to raise their hand and kind of self-identify who they are. And then we can show them a lighted path by which they can go down and choose a good match for them within the system that they're looking at. So this SaaS product allows us to help our clients and customers drive patient acquisition and retention. Obviously, we're looking to improve patient and provider satisfaction, but that's kind of just the front end of it. The other part that we really like about it is that we are gathering all this data. Nobody else is in the system or in the industry is really gathering this kind of data on patients and providers before a first appointment. Sure, afterwards they may have a satisfaction survey, or you're going to have more clinical data, et cetera. But nobody's gathering information on these people before they enter into the system. And so we have an opportunity to give this data to our customers, and they're able to use it. We establish, when somebody comes through and they take a quiz, we assign them a patient personality. So as you kind of see on the screen there, it says, hey, well done. By the sounds of it, you are a front runner, right? And we give them an idea of what that means. So it gives them some confidence in who, how they've self-identified and who we're showing them as matches. but we can also take that data and know who they are and give that to our customers and help them from a marketing standpoint with their messaging, right? They may feel like, you know, they've got a certain kind of demographic or people in their marketplace, and really it's something completely different. And so it's able to help them be more precise in their messaging and their marketing. But then also from a provider standpoint, we kind of assign personalities to who they are too. And we can tell the HR department at a health system, hey, listen, you don't have enough providers that kind of fit this personality profile, right? But the problem is that you may have 50% of your marketplace needs that kind of provider. That's what they're searching for. So when you're out there looking to hire new physicians, just keep this in mind. It's just another data point to kind of go off of as you're going through and going through candidates there. So the user journey for them really looks like, you know, a patient, they're going to go on to a health network's website or app to search for a provider. They would be prompted to take our quiz. Most of the time, that's going to be something on the homepage or on the Find a Doc page. They say, hey, don't know what you're looking for, take our quiz and match with the right provider. So they go ahead and they do that, 10 questions, takes them about 90 seconds. Once they do that, they see their patient personality. We give them their provider matches. They can go through there, use those filters to narrow down even further if they would like to, because we do present that based on compatibility first and foremost. And then they go ahead and schedule their appointment as they normally would on the website or app. We can integrate with online scheduling or forms or however our customers need it to be. We meet them at that point of technology. From the provider side, when we sign on a new customer, they give us a list of the providers that they would want to be included as part of this platform. Once we get that, we email them a questionnaire, and it takes them, 10 minutes or so at the very most to go through it. And from that point on, their work is done. There's nothing else that they have to do. And then they go through, they have that appointment, and then there's that patient provider feedback loop, like, was this a good match for you? Do you think you're going to come back and see this provider? You think you'll have a good relationship moving forward, et cetera. So if our customers do not have a satisfaction survey that they normally send out, then we have something that we can put in place to kind of gather that information as well. Just give you a little bit of idea of our current traction. Again, we're a startup, so we do have some good traction up front. We do work with Advent Health here in Kansas City, CHI Health up in Nebraska and Iowa, and then Sanford Health in the Dakotas and Minnesota. So for our proof of concept program with Advent Health, 1,300 new patients, this is over about a 3-year period, 1,300 new patients came through, took the quiz, and then ended up going to appointments. So not just scheduled appointments, but actually showed up, right? Which is always a good measuring stick. And then from a retention standpoint, a lapsed patient standpoint, 900 of those folks who in the previous 2 years had no interactions with the health system, but were previous patients, ended up coming back into the system, took the quiz, and had appointments. And so between those two parties, drove about $12 million in payments to the system, which obviously they were pretty excited about. But the cool thing is that we got to show that we helped improve their new patient growth by about 3% versus their year-over-year average. And then folks who came through and participated in the quiz and were new patients had about one more encounter per year than new patients who did not. And so what that was telling us was that they were finding providers that they were listening to, being more compliant with. Maybe we're going to specialists that were being recommended to them by the PCPs. And so that was good. We're getting some of that patient stickiness that we were talking about, right? And then from a satisfaction standpoint, specifically on the provider side, 70% of them said that this was kind of an always-on marketing program for them, that again, they had very little that they had to do, but they felt good being a part of it. And then 50% said they were seeing more of the types of patients that they would prefer to on a daily basis, which was kind of cool, right? I mean, they're attracting more of the kinds of people they want to see. And then 30% actually said they had a higher job satisfaction just being a part of the program, which was always nice. And so just give you a little insight on how we kind of promote this and who we sell to. So again, we sell to health systems, to payer networks, to large provider groups and telehealth companies. And I know traditionally telehealth has been usually who's the first available, get me in, I'll see them, right? But obviously in the times of COVID, and I feel going forward, telehealth is going to be used more and more from a relationship, PCP kind of basis. And so if I'm here in Kansas City and I feel like the best PCP for me might be in Anchorage, Alaska, that's going to be a possibility for me moving forward. And so being able to kind of go through and really narrow down that pool of candidates on who might be the best fit for me personally, this is going to be a great way for them to do that. And so we have a monthly subscription fee, and it's based on the number of providers that our customers would want to enroll. So rural hospital might be up to 50 providers, and they would pay us X amount of dollars a month, or up to a larger system. And then we have two different license types. One is web license, which is essentially, for lack of a better term, a plugin that goes onto their website, can be placed on any page that they want. And then we have an API license that if somebody wanted to put it into their app for more of a customer shopping, patient shopping experience for a doctor, they can do that as well. And then from a competition standpoint and really complementers, nobody is really doing what we're doing currently. Obviously, everybody has a Find a Doc tool, and it'd be really easy to just kind of write us off as another Find a Doc tool, but we're really trying to fill a gap in the experience, right? And we feel like we're doing that with our patient provider predictive matching. There are obviously consumer sites out there like a ShareCare and a ZocDoc that are really more focused on appointment scheduling and finding the right appointments or open availability. There's systems out there like a Kairos, which is more of a provider management tool, and it's really good once you get in the system. They do have a Find a Doc tool called Provider Match, but it's really just a search engine more than anything. And so, and then there's EHRs as well. So again, nobody's really doing what we're doing. We can integrate with any system, and we really try to talk about how we're not necessarily trying to replace current Find a Doc tools. We're really trying to fill that gap and work alongside them. And so for the most part, our customers are using us alongside what they already have. And it's giving their patients a different / better experience moving forward. And then I'm not going to dwell on this slide, but if you know anybody who is, an investor or anything like that, we are actively raising capital. And so again, it's a big industry. We're a very small team, and so we're trying to attack as much of it as we can. We've been very focused on health systems. We think payer networks would be a great fit for us, and so any introductions anybody would have, we are always grateful for. So with that, I'm happy to take any questions, and we really appreciate your time today and being able to talk to you all. Thank you.
Thanks, Bob. That's really great. Can you say a little bit more maybe about the engagements that you've had with providers so far? Or how long have those been going on, and what other kinds of results are you seeing coming out of that?
Yeah, no, it's a great question. So Advent Health, we originally started this with them probably close to 5 years ago, and it's active now on myhealthkc.com. So we helped build them this website and kind of a hub. And so really that was the proof of concept for it all. We took on CHI Health probably about 2.5 years ago. And they're currently waiting to get our newest version up on their website. But we had created a website for them too, similar to what we did for Advent Health here. And they saw similar results, right? I mean, they're driving a lot of new patients and getting a lot of great feedback from providers as well. And I'll give you an example. One of the questions I get quite a bit is, how do you get the providers to take the quiz, right? I mean, it's 10 minutes out of their day and everything. And so for Advent Health, they made it a requirement that all their PCPs had to do it. And sure, there were a couple stragglers, but I would say about 99% of them did. CHI Health made it optional. And so out of about 250 primary care providers, they told them, hey, here's a new program we're going to bring on. Here's why it's beneficial to you. Here's why you should do this. Out of about 250, 100 of them did it right away. And about 6 months later, another 100 had signed up. And so that was kind of a eureka moment for Jim and myself, because we're like, okay, they're talking to each other. You know, they're seeing that it's working for their colleagues and they don't want to miss out, which obviously is a great feeling for us, but it's good for them too. And then Sanford actually just rolled out last Thursday on their website. So if you want to go to sanfordhealth.org, you can check that out. It's on the homepage there. And so they've got about 750 providers that they gave us originally. And I think we've got about, you know, around 600 right now that are in the database that have taken the questionnaire. So they're very excited. They've got a large campaign plan for 2022 that is built around this whole matching up of patients with the right providers.
John, another thing I would add is we're having to meet each of our clients at different points in their own digital experience, right? That some of them have online scheduling, some of them don't have online scheduling. So we've made the technology pretty light. It's as easy to install as Google Analytics. But there's some level of customization around the individual health system and their workflow for onboarding patients.
Right. It's and so far driving people to the website is mostly through matching up at the landing page of this health system currently. You aren't doing any additional marketing on top of that. Is that correct?
Yeah, that's correct. We're essentially white labeling this for them, right? Mm-hmm. So they're putting it on their website or their app, and then they are the ones who are driving folks in their marketplace to use it. So, you know, we could have gone a couple different ways, and we still may go a couple different ways with this moving forward, right? And be more of a B2C for, you know, specialties. Maybe it's behavioral health or plastics or something like that. But at this point in time, it's a better business model for us to go directly to the systems or the networks, and then they just implement it and go ahead and promote it on their own.
Right. Yeah, I could see where it could be very much a integral part of their own campaign.
Yep, very much so. And that's the thing, right? I mean, for so long, a lot of independent PCP providers out there, they were getting marketed to by the health systems themselves, right? Well, at a certain point, during the ACA, they had to go ahead and decide, am I going to buy an EHR and kind of stay on my own, or am I going to go join a health system? And the majority went and joined a health system. And so with that, the health system's like, great, I've got all these providers. Now I've got to market them somehow. And there just isn't a really compelling way to market primary care providers specifically, right? I will point out this works for any specialty, but most of our customers so far have used it for primary care because it is the top of the funnel for their system, right? It is the front door. And so if that is the front door, we see this as kind of the screen door to that front door.
That's great. Thank you. What about questions or comments from the rest of the team? Anyone have any thoughts?
Hey, yeah. Hey, Bob, thanks. I think this is really interesting. More I think about this, well, I had a couple of questions and sort of comment, see if it's something you guys have thought about. It seems to me the real opportunity here is on the side of quality and outcomes, and particularly things like compliance. And I'm just wondering if you've thought about studying that. And it's one thing to drive volume and stickiness, I guess, but it seems to me that the real interesting goal with this work could be around quality and compliance as it relates to, patients doing better with matched with providers who are, better for them. And I'm just also in conjunction with that curious about, it seems to me a primary customer, this would be health plans. And so I'm just curious about that.
Yeah, no, great question. And the answer to all of that is yes. So the issue is, from our standpoint, we know health systems better because that's what our background is, right? So that was kind of I wouldn't say it's an easy way in for us, but it was a good start for us. We are definitely open to working with payers. They're looking for, as you alluded to, they're looking for different indicators of success, right? And so far we haven't been able to find a narrow network even to kind of work with, to kind of show some sort of longitudinal study, over 12 or 18 months. And I understand, like, they want to see cost savings. We want to see it too, right? And anecdotally, we believe it is happening. We just haven't been able to work with anybody yet to do that. And we want to be able to show that, yes, better relationship means that you're more compliant and you're adhering to protocols and doing what your provider says, because that relationship is built on that trust that you have with the provider. So yeah, absolutely. So if you know of anybody, I'd be open to.
I mean, we would love to. We do it for free to get that going, right? Because we need that data.
Yeah, I'm not really my role. I have some ideas about that, but maybe a little outside my bailiwick. But
yeah, well, I appreciate the thought. Thank you.
I just say I've been in healthcare for 30 years, and I probably know more than the average bear about a lot of this stuff in terms of patient, physicians and quality, and I still struggle trying to pick a doctor. So I think it's a nice niche.
Yeah, no, thanks. And it is it's a problem that everybody has at some point in their life, right? I mean, you need to find a doctor at some point. And whether you're transitioning out of, a young person transitioning out of just going to an urgent care all the time, or you got to get off of your parents' plan, you got your first job or something like that. Yes, you may not need it all the time, but it is good, because some of the feedback we get from these providers, for example, one of the docs here at Advent Health said, I'm seeing 22-year-old guys in my clinic for the first time ever. He's like, I've never gotten that before. He's like, they didn't know I existed until they found me on this thing. And so that's cool to hear. And so obviously that helps with his satisfaction just as much as the patient's.
One question I have with you talked about the younger generation, but how about, as more people may be retiring early, is there an opportunity for this to match, healthcare.gov plans with doctors to say, okay, these are the doctors in your area that match these plans, so that it's very easy to connect a plan with a doctor that works for the patient?
Yeah, we're actually actively in talks with some Medicare Advantage programs, because I think that makes so much sense as people roll off of their private program onto some sort of government program, that they're really tossed back in the pool of having to find the right provider for them. So yeah, I think that makes all the sense in the world.
It's a great question. All right.
Any other thoughts? Well, it does seem like just a really nice step forward. That issue of compatibility with the provider is something that it seems like nobody ever really thought of before. In a way, this does represent a real step, and we certainly appreciate your time and efforts in presenting to us today. Do you have any thoughts you want to share before we sign off?
No, just again, really appreciate the time, John. Thanks for the invitation. And again, loved hearing about Children's Mercy this morning too. That's fantastic. Thank you.
Yes. Well, yes, thank you to all our presenters today. We didn't strike any particular theme between the two, but we just saw really great quality and engagement with both, and we're very grateful, and thank you for your time and efforts. And with that, I'll sign us all off. Thanks again.
Thank you.
Bye.